think you probably all need the dose of the GLP yourselves. But thank you very much. I know it's a Friday afternoon. And I know when she mentioned GLP-1, most of you must have been like, oh no, not again. But trust me, there's so many facets to the GLP, and this is a newer aspect that you're going to have a look at today. So my talk is named ABCD management. How many of you have a clue what the ABCD stands for? Oh, only 2 people. Okay, so I guess I have a lot of work to do, but anyway. So this is a disclaimer. This is a sponsored talk by Beximco. So that's the outline of my talk. So I'm going to define what ABCD is and what it is about, the epidemiology, the classification, assessment, weight loss therapy, major trials for the efficacy of weight loss therapy, adverse effects, and just one case study. So ABCD stands for adiposity-based chronic disease. So we're moving away from the terminology obesity, and I'll tell you why. So adiposity-based chronic disease is an approach to obesity that views it as a chronic disease caused by excess and malfunctioning adipose tissue. So basically, obesity is no longer a risk factor for cardiovascular disease, type 2 diabetes. It's a chronic disease on its own, and the pathophysiology behind it is that there is excess fat mass, and there is malfunctioning of this fat mass that is leading to the chronicity of the condition. So basically, it's not solely based on BMI. It emphasizes a complication-based approach, because all the effects that you're seeing of obesity, type 2 diabetes, and all that is a complication of obesity itself. And it incorporates, the ABCD incorporates the impact on health, which is related to the quantity, the distribution, and the function of the adipose tissue. So if you look at that diagram there, the 3 entities of the adipose tissue is the distribution. Where is this fat? Where is this adipose tissue? Around the abdominal area. This is associated with insulin resistance, type 2 diabetes, atherosclerotic cardiovascular disease, and all that, cardiovascular mortality ultimately. And if you look at the distribution around of fat mass, or rather adipose tissue around the gluteofemoral area, this has been shown to be cardioprotective actually. So for people who have a lot of adiposity around the gluteus area or the femoral area, they've been shown to be cardioprotective for them, but the abdominal area, not a good area. So the function, if we look at the adipose tissue, so we know adipose tissue is an endocrine organ, and when you look at the malfunctioning, so when you have excessive accumulation of the adipose tissue, there tends to be the malfunctioning that comes up, and so you get the adipokines, you get all these cytokines, the pro-inflammatory cytokines, interleukin-1, interleukin-6, all being produced to perpetuate a pro-inflammatory state, which eventually leads to cardiovascular risk and eventually cardiovascular disease and mortality. And so the amount, so this excessive amount eventually leads to the distribution, the malfunctioning, but the amount itself has a mechanical effect. When you look at obstructive sleep apnea, when you look at osteoarthritis, all this is a function of the mechanical aspect causing the pathophysiology. So the fat mass disease, so it's a fat mass disease, and it's a sick fat disease, in the sense that now the metabolic aspect comes in with the derangement of the immune response and the endocrine response. So why ABCD? Why not obesity as before? Because the word obesity is not precise. It defines excess body weight as opposed to fat mass. Remember, the pathophysiology is mainly the fat mass, the adipose tissue. And again, the term obesity, over the years, the connotation with the term actually has a lot of stigmatization and negativity attached to it. So moving away from it, because we don't want to tell patient you have obesity. So it's much more better to say you have adiposity-based chronic disease. And obesity is defined by the BMI. So there is nothing there talking about adiposity-related health risk associated with the disease itself. So that is why we now prefer calling it adiposity-based chronic disease. So now, do we know what ABCD means? Great. When we come to the classification of obesity or ABCD in general, we've been using the term BMI. And so BMI is really not accurate. It's better for epidemiological studies to be used in that kind of scenarios. And yet again, for our population, it's really not quite accurate that we use the BMI. And why is it? Because it does not measure the fat content or account for the muscle mass, neither does it consider bone density, nor the overall body composition, or the racial and the gender differences as well. It does not put that into consideration. And so, and all this matters when it comes to adiposity-based chronic disease. So we prefer using the term, we don't prefer using the BMI anymore. So you'd rather classify it with probably use the Edmonton obesity staging system, and this considers the presence of obesity-related risk factors like the physical or the medical aspect of the condition that is associated with it, the physical and the psychological symptoms. So based on that clinical, for example, you're having your seeing your patient, what the patient is presenting with. Physically, if the patient has hypertension, if the patient has type 2 diabetes, if the patient is having hyperlipidemia. So based on all this, the presence of all this, you can stage from stage 0 to 4, and the mental aspect, so you have to look at the mental aspect of it, and the functionality of the patient. So based on this, you can classify with the EOSS system. Even better, the phenotype of the patient, how the patient looks. So we have this that has been now the talk in terms of how the patient appears. We have patients who are lean and they're metabolically healthy in the sense that they don't have any comorbidities associated with the metabolic aspect. And we have the metabolically unhealthy lean. So we have a lot of these patients. For example, you have what we call the lean type 2 diabetes patients. So these are the patients who fall here. And we have the metabolically unhealthy obese. They are obese and they have all the other associated metabolic dysfunction like type 2 diabetes, non-alcoholic fatty liver disease, dyslipidemias, and the cardiovascular disease. And then you have metabolically healthy obese. This patient is obese but has none of that. So now, when we look at this classification, there is a study which was published in 2021, which said this could be quite misleading because you have the metabolically unhealthy lean patient there, who you would probably classify as very high risk, and you have the metabolically healthy obese patient there, who you'd think does not have any risk at all. But just the increase in that fat mass already gives you that high risk. So that patient who you're calling metabolically healthy obese still has some risk of cardiovascular death as compared to the lean patient. So these terminologies, there's some quotas which tend to say that it can be misleading and could not be quite accurate. So coming to obesity. In Africa, we have, this was in 2022, and if you look at the prevalence rates, the North Africa, they're leading with Libya at 32.5%, and the least there in Ethiopia at 4.5%, and Kenya at 7.1%. Not sure whether that is very accurate, but I'll let you be the judge of that. And coming closer to home in Kenya, the female compared to male tend to be more obese. And if you look at the area, sorry if it's not very clear, but I'll read for you. Kirinyaga, Nyeri, Murang'a, Nairobi, Nyandarua, Kiambu, Embu, Nakuru. So if you'll notice, that's around the same area where there's a lot of obesity, and Lamu down there. So if at least the majority has been noted to be around one area. Probably that's could be a hypothesis for somebody to follow it up why there is a lot of obesity in that area. And for the male, which is the prevalence compared to female is much less, and Kajiado, Kiambu, Lamu, Nairobi City, Kirinyaga, Nyeri, Isiolo, Nakuru, Mombasa are among the leading in terms of prevalence rates. So, why are we discussing obesity? Obviously, we know the complications associated with it in terms of type 2 diabetes, cardiovascular, hypertension, osteoarthritis, sleep apnea, stroke, and all that. And all this can be prevented with a reduction of obesity. And just by 5 to 10% weight loss, you can have that reduction. So, in terms of the type 2 diabetes and cardiovascular mortality especially will be reduced just by that reduction in weight loss. And so when we come to manage these patients in the clinic, I hope this slide is quite clear because I want you to look at it very clearly. Remember I said we are moving away from the term obesity because of the connotation of stigmatization and how we manage this patient. So if you look at this, it's the 5 A's of managing obesity. Please take your time and talk to the patient. Ask permission to discuss their weight because for them probably weight is not a big problem. And for them it could be a trigger if you mention the word weight. So please always find a way of talking to the patient. I think I'll keep insisting on this issue of language matters in terms of how you approach the patient. Ask for permission. Assess the physical in terms of history, medical examination, and your investigations to at least look at whether the patient has already developed complications and look at the barriers as well. And advise the patient on the benefit of modest weight loss. Agree on realistic weight loss expectations. I think this was tackled yesterday by Dr. Eric Njenga. Expectations, very important for you. And from the beginning, setting of the goals. And these goals have to be smart, very realistic goals. And this has to be from the outset. And you assist in addressing the barriers. So this is quite a familiar slide, I think, in terms of causes of obesity, the genetic, the environmental. Don't forget to rule out secondary obesity from the endocrine conditions, hypothyroidism, Cushing's, insulinoma, and psychiatric disorders. Another important one I would want to mention there is the medication. Please look out for the anticonvulsants, antidepressants, and the antipsychotics, and obviously the hormones, the steroids, and also not forgetting insulin. So if you look at the treatment algorithm there as we're managing these patients, if you have overweight patients, please assess if this patient is motivated to lose weight. If not, have them being cancelled and take them through the process, take them slowly and don't rush them. If they're ready to lose weight and they don't have secondary obesity, you can assess the degree of obesity and other concurrent risk factors associated with it in terms of the hypertension and the dyslipidemias. If the patient, I'm not sure if it's clear, but if the patient is having BMI of greater than 27, 30, no risk factor there, you can have BMI of 27 and less than 30, and with other no risk factors, you can consider the lifestyle therapy. Please don't forget, for weight loss, foundational therapy at the beginning, from the outset, we never leave lifestyle modification, because even as you give other therapies, even if this patient goes for bariatric surgery, they'll still need lifestyle modification. You cannot leave that. So that is at the base of all of it. But BMI above 35 and a risk factor, you'll consider medical therapy, and BMI above 40 with risk factor or with no risk factor, can consider bariatric surgery. And so when we talk about drug therapy or anti-obesity medications, what are we looking at? They work in the mechanism of action, two locations, centrally and peripherally. If you look at centrally, we have all those, the phentamines, topiramate, naltrexone, bupropion, phentamine, I think, alone, which we have in the country, and the tirzepatides and the GLP-1 analog, the GIP and the GLP-1 analogs. And the peripheral acting, you have the Orlistat and the hydrogel. So if you look at the weight reduction associated with those, weight reduction as a result of those medications, you can see there that phentamine, topiramate at 8.6% and semaglutide at 12.4%. So I think we already know this, and GLP-1s, it's a hormone, it's an incretin hormone produced by the L cells, and this was covered quite well. I'll go straight to the studies which were done on semaglutide to see weight loss of So these were randomized control trials, double-blinded. They were done with semaglutide 2.4 milligrams versus placebo to be able to see the efficacy of weight loss for patients at different stages. So this population was quite similar with what Prof. Kunyiha discussed in the morning for the SURMOUNT trials. If you look at step 1, it was purely obese patients with no comorbidities, and step 2 were obese patients with type 2 diabetes, and step 3 with obese patients with intensive behavioral therapy, and step 4, sustained weight management. This was a run-in, which I'll show you, and step 5 was long-term. So if you see, there was dose escalation for the first 16 weeks. You can't start this drug at 2.4 milligram. There has to be dose escalation from 0.25 to 0.5 to 1 milligram, 1.7, and you then go to 2.4 milligrams. And the primary endpoint for all the step trials cut across was weight loss. So that was all they're looking at. So that was the step 1 trial, and you can see that comparing semaglutide 2.4 milligram once weekly and placebo, there was a 14.9 reduction at 60, so 14.9% weight loss at 68 in the semaglutide group. And this was quite significant because you can see that the placebo had only 2.4%. And the step 4 trial, so step 2 trial was with type 2 diabetes patient, quite significant as well. Step 3 was with intensive behavioral therapy. All these studies from step 1 to step 5 had lifestyle modification, but the difference in step 3, which had intensive behavioral therapy, was there was associated coaching and patients were followed up more, and it had a significant amount of weight loss. What I want to show here is in the step 4 is that there was a running period of 20 weeks where patients were all given semaglutide, and then they were randomized to placebo and the semaglutide group. If you can see the patients who are switched to semaglutide, they actually had increase in weight. So those who stopped gained the weight. Those who continued continued losing the weight. And the step 5 was over 2 years period, the long term. And it showed that continuous use of the drug led to continuous weight loss therapy. What am I trying to say? This is adiposity-based chronic disease. It's a chronic disease, and this is the medical therapy. It's not a quick fix. You need to continue maintaining on the drug for you to have continuous weight loss. Adverse effects, I think, widely discussed. I just want to bring out one thing. If you want to start a patient on semaglutide, please look at their eyes, especially the pre-diabetes and diabetes patients. This morning, I think one of the questions was patients with pre-diabetes developing diabetes macular edema. Semaglutide has been shown to worsen retinopathy. Please make sure your patient does not have pre-proliferative diabetes retinopathy, or these patients don't come to you anyway to tell you, look at my eyes. So look at their eyes before initiating. You might end up causing more harm. So the other ones are obviously the GI effects and obviously the thyroid cancer, which were talked about here yesterday by Dr. Eric. And then again, there goes the Ozempic phase. A lot of the patients we are seeing who we are giving these drugs, their motivation is not adiposity-based chronic disease. It is how they look. It is they want to look better. And so when you give this therapy, you have to discuss the potential side effects. And one of it is this, because they'll end up looking older in terms of having a bit of sagging skin here and there and having a bit of more wrinkles, so what we call the Ozempic face. So just caution them on that, because everybody wants to look like that. So if you make them ending up look differently, that is, sorry I had to put that because as Eric said, she's the poster girl for this. So if you make them look worse than they had before, someone might come gun blazing at you. And so I'll give you a case. So our patient, CW, 44 years, had a weight of 124.7 kilograms when we saw her, and a BMI of 42, and body fat of 59.3%, and skeletal muscle of 18.5 kilograms. She works for some international organization. Her travel plans and eating plans are quite hectic, and she doesn't want to have a really small body, but she would like to lose weight. She does not have any comorbidities. So we are working with this patient, with Betty. I don't know if she's here. She was the nutritionist on board. So she changed all those diets for her from 3,000 to 2,000 kilocalories and recommended some weight loss, some workout. So 1 month later when we saw her, she had lost a bit of weight, but of importance there is, she lost about 3 kilograms, and we had started her on semaglutide at 0.25. But of importance is that she had started losing her fat mass. We up-titrated her dose from 0.5, went even up to 1 milligram. She kept doing her strength training exercises at home. What was of importance here is that, look at her weight. Her weight did not reduce significantly. What reduced significantly was her body fat, and she gained her muscle bulk. In fact, she didn't double, but almost doubled her muscle mass. So what am I trying to say here? What I'm trying to say here is that we are managing a condition not only the way the patients look and how they want to look. The sense that this patient might not have lost much weight, because again, remember, if we're calculating BMI and we're looking at that BMI, we're still going to have a high BMI because the muscle mass will still contribute to the BMI because it's going to contribute to the weight. So this patient became more healthier in the sense that she's reduced her adiposity, she's gained more muscle mass. So the focus should not just be on the weight itself. The importance of doing body composition analysis is highlighted here in the sense that the driver of the complications is mainly the adiposity, the fat mass. So just don't look at the patient and say, hey, your BMI is still this and we're giving you this. So this patient is still continuing with therapy with the sense that she's now at 1.7 milligrams and she's still continuing doing well. So I think with that, I am done. Can I say my take home? Sorry, this was not working, but I think I did. So renaming obesity, adiposity-based chronic disease, acknowledges the chronic metabolic dysfunction associated with what we currently term obesity. Focus on adiposity rather than BMI for a more accurate assessment of health risk. Person-centric approach. Semaglutide has been shown to significantly aid weight loss, with trials demonstrating that. And lastly, educate and empower our patients about the benefits and realistic expectation of weight loss, ultimately.
Oh, another applause. Thank you, Dr. Edan, for that. I think this is the one drug that even the gynecologists are prescribing. So maybe this should have been a CME for everyone to know, because everyone is prescribing this drug. So I think we can take 1 or 2 questions, and I request as you ask your questions, you limit it to the question in the interest of time.
Yes, Jackie. My question is, Dr. Rilwan, in as much as you're right, your patient didn't lose as much as we thought she would. She lost the 3 kgs. The important thing was she lost her body fat. So the question for our population, should we be doing body fat composition and using this as a guide instead of our usual BMI? And I can see the new dietitians are just nodding their head. So maybe I'd like a comment with regards to that, because that's, I mean, you have the audience and it's something we are doing as endocrinologists. Maybe you can comment about that.
Absolutely.
We take the other question and then you can answer them together.
Okay. Thank you, Rilwan. That was a very good presentation. I don't know that there's any other neurologist in the audience. I was quite alarmed when all our drugs flagged up as a cause of obesity, most of our anticonvulsants. It's probably a caution that when you find your patients on those anticonvulsants, maybe feedback to the neurologist, don't stop them, because anticonvulsant therapy is key, and unfortunately most of our drugs may cause obesity. But a lot of thought process goes into selecting the drug, because you want to find out, does this patient suffer from other side effects? What are the comorbid conditions, depression, osteoporosis? You're combining a sodium channel blocker, gabapentin, the GABA drugs. So caution is don't tell the patient to stop their medications. Just call the primary physician and see how to work around it, because the only anticonvulsant drug that is known to cause weight loss is actually topiramate. Most of the others will cause weight gain, but we don't have such a large armamentarium of anti-seizure medications to use. So stopping the meds is probably going to cause that patient more problems. Maybe use your Ozempic and ask them to exercise and change their diet. Yeah.
Thank you, Sylvia. I think that's a very important point. As I mentioned them, I was mentioning for you to pick it out in your history as the causes, potential causes for obesity. But that's a very good point. Always refer back to the neurologist. Thanks, Sylvia. For Rosie's point, I think it's absolutely important to do a body composition. What I've come here this afternoon is to emphasize that obesity is an adiposity-based chronic disease. So you need to know how much adipose this patient has, because this is the driver of everything else: insulin resistance, type 2 diabetes, hypertension, atherosclerosis, pro-inflammatory state, every other thing. So it's important for you to know how much fat this patient has. So if you have more muscle mass than fat mass, and so the BMI is still going to be high, and they're still going to be grouped into obesity. That's why where you come from, you're probably seeing more stronger ladies, and you're not finding the adiposity-related complications that we're seeing. That could be the reason. And the question around the waist-hip ratio, I think the waist-hip ratio can be better accuracy as opposed to the BMI, in the sense that when I described the ABCD in terms of the adiposity distribution, the fat mass around the abdomen is more associated with cardiovascular risk and cardiovascular mortality as opposed to the gluteofemoral fat. So if you want to assess the health risk, at least I think the waist circumference, the waist hip ratio might be a better factor to use again than the BMI. I don't know if I've answered all your questions, Doc. I think there were those two. Okay.
Thank you. Thank you, Dr. Adam. Give another clap. So I think one thing we can pick from this topic is the more we know, the more we need to know, and it's a very wide topic. And I think that idea for a one-day symposium is something that maybe in the future we can work on. So I think now I want to, not I think, I know, I want to hand over the mic to Dr. Jemima to take us through the next session.
Thank you very much. That was a very lovely talk, but we are going to shift gears. We've had enough of endocrinologists, and we want to hear from other physicians because the body is one. You can't separate it. But before we do that, I would wish we'd all stand and do a little activity. Please stand up. We are going to figure out who are females and who are males in this house and who have some confusion. Please stand up, everybody. So we are going to sing this nursery song. Is it a nursery one? It's a Sunday school. I hope even the Muslims have some Sunday school, some mosque song. But this one is, I will make you fishers of men, fishers of men, fishers of men. I will make you fishers. Any time we say M, the men should sit. And we are going to be judging who are confused, who know. So let's start. So every F, the ladies sit. Every M, the men sit. Let's start. I will make you fishers of men, fishers of men, fishers of men. I will make you fishers of men if you fall. Quite a bit of confusion. Good. Okay, let's be seated. We can all sit now. Some men got very scared of sitting. Anyway, so we are going to shift gears. We are going to look at a topic, the deadly duos. It sounds scary, and it is scary when big diseases combine forces to finish people. And our speaker now is Dr. Abdi Saliani, a consultant physician and infectious disease specialist. Dr. Abdi? Abdi. Huh? Adil. Okay, sorry for that. Yeah, so Dr. Ari, please take us through the topic HIV and diabetes.
Thank you. Okay. So thank you, Kdsg, for inviting me to give this talk. One of the disclosures I have is anytime you see obesity, please read ABCD. So what we'll cover today is we'll look at the epidemiology of diabetes in HIV, and then we'll look why it's called the deadly duo, what are the consequences with regards to cardiovascular disease, renal disease, peripheral neuropathy, and survival, and then we'll look at management considerations of these conditions. So looking at the epidemiology of diabetes in HIV, so we know that with combined ART, the lifespan of HIV patients is increasing, and it's actually approaching the normal population. And with aging come the diseases of aging. But in these people now, apart from the traditional risk factors brought about by aging, they have another risk factor, which is the HIV infection, which together with its treatment increases the metabolic complications in the body. So right now, patients with HIV actually dying of non-AIDS related conditions, predominantly cardiovascular diseases and malignancy. And diabetes, which was very uncommon in the pre-ART era, is actually become quite prevalent, ranges between 2 to 14% depending on the population studied. And there's really conflicting evidence whether HIV is an independent risk factor for diabetes or not, and we're going to look at that. So why is there a link between diabetes and HIV? So I like to divide them into three. So there is the risk factors brought up by the HIV itself, which is HIV-associated inflammation, which causes insulin resistance. And then there is the effects of the ART, which we are going to look at in some more detail, including insulin resistance, hyperlipidemia, lipodystrophy. And then there are some conditions which are more common in patients with HIV compared to the common population. I think this is more common in the Western compared to what we see here because of the mode of acquisition of HIV in those patients, but they have more chances of having co-infection with hepatitis C, and because they get it by IV drug use, they also have opiate use. And then medications which are more commonly used in HIV patients, including steroids, which use for iris, and then because of mental issues, they get atypical antipsychotics. In addition to the traditional risk factor, which is increasing age, and then ABCD and genetics. So, because of all these risk factors, is diabetes more prevalent in HIV? So let's look at the literature. We'll start off with the West, and particularly North America. So this was a large study. So, you know, in the West, they have databases for everything. So this was comparing two databases. So there is NHANES, which is nutritional health, and NAS is like a study, and which looks at the general population, and then we have the MMP, which is the HIV population, and then they compared the risk factor, the prevalence of diabetes in these two populations. And what we see is the prevalence is much higher, 11% compared to 8% in HIV compared to non-HIV, and this is a statistically significant difference. Other things that we saw is like the risk factor, like the prevalence is much higher in those patients you expect to have higher prevalence. So if you look at the age, those more than 60, the prevalence was like 21% compared to 19%. And if you look at patients who are obese, the prevalence was much higher. But what was notable in this study is the ones who are considered less likely to have diabetes, actually there was a higher prevalence in HIV compared to those who did not have HIV. So if you look at the ages of 20 to 44 and 45 to 60, the prevalence was much higher. And if you look at those who are not obese, they had higher prevalence in HIV. That says that there is something about the HIV infection or the therapy which is predisposing these patients to have diabetes. And this was another study. This was done in Italy, where they compared patients with HIV compared to healthy patients like healthier controls who didn't have HIV. I can't say they were healthy because they also had diabetes. So the prevalence of diabetes was much higher in HIV, 4.5% compared to 2.1%. And they looked at risk factors for developing diabetes. So there were the traditional ones, which was increasing age and then increased BMI, but also HIV was an independent risk factor for developing diabetes. So definitely there's something there. However, studies in Africa is more mixed. So this is a meta-analysis which looked at around 20 studies which were studying the incidence prevalence of diabetes in HIV compared to non-HIV. So they looked at HIV infected versus uninfected, and you can see the forest plot is all over the place. Although the relative risk is a bit higher, it is not statistically significant. And because ART is considered a risk factor for developing diabetes, they looked at patients who are on ART compared to those who are not on ART. And again, the difference was not statistically significant, but the studies had a lot of heterogeneity, so we might not be able to rely on these conclusions. So we've been talking about ART and diabetes risk. So generally, these drugs which confer increased risk are the older drugs. So the first generation protease inhibitors, indinavir, ritonavir, nelfinavir, and amprenavir. Of these, I think people only use ritonavir, but what we have to note here is the ritonavir they're talking about was the one which was used as protease inhibitor, not as an enzyme inhibitor right now, which is used to boost the other PIs, and it was much higher doses. So the mechanism by which they cause diabetes is because of insulin resistance. So they blockade the GLUT4 transporter, which transports glucose into the muscles and the adipose tissue, and also because they cause a lot of lipodystrophy. Also, they act directly on the beta cells, causing decreased insulin secretion. And then the thymidine analogs, so stavudine is no longer used. Zidovudine, you will sometimes see it being used, especially in second line and third line. And these ones, they cause diabetes by causing insulin resistance due to mitochondrial toxicity and lipodystrophy. So the incidence of diabetes really peaked initially because of use of this drug, but now that they are out of the market and not being used, they declined. Now what about the new ARVs? So just to remind everyone, the current first-line treatment is TDF plus lamivudine plus dolutegravir, which is an integrase inhibitor. So for those who have osteoporosis or renal dysfunction, we use tenofovir alafenamide, which has less of these toxicities compared to tenofovir disoproxil fumarate. So with the increased use of these drugs, now it's being noted that these ones, especially in combination, the dolutegravir and TAF, are significantly associated with the weight gain and obesity. And INSTI use has been associated with hypertension, while TAF use has been associated with dyslipidemia. When the INSTIs were initially rolled out, there were a lot of cases of patients presenting with weight loss and then DKA, and that led to a lot of alarm. So this led to this meta-analysis by Mulindwa, where he looked at patients who are on INSTI and compared to those who are not on INSTI, and checked if there was increased incidence of diabetes. It wasn't there actually, except in patients, in African patients living with HIV. So this is something we definitely have to watch. So I would describe the consequence of diabetes in HIV as double trouble, and you'll see why. So this was the DAD study, which is a large study. They prospectively look at like 33,000 HIV patients in Europe, Australia, and USA, and prospectively follow up the outcomes. So they were trying to answer the question, because in patients who do not have HIV, diabetes is considered a coronary risk equivalent, as if you have already had a coronary artery disease. So they looked at, does this apply to HIV patients? So if you see that there is the comparator, which is patients who have HIV who do not have coronary heart disease or DM, and then they compared to those who had coronary heart disease but no CHD but had DM, and then who had CHD but no DM, and then both. And you can see that just having DM increased the risk factor of getting another coronary event by 2.4%, but then those who already had coronary heart disease was 7.4%, which was much higher, and it went to 10% with both of them. So definitely it does increase the risk by a factor of 2.4. When it comes to renal disease, we know that HIV infection leads to proteinuria and leads to the nephrotic syndrome called HIVE-1. So they were trying to analyze whether if you have HIV and diabetes, does it predispose you to have more proteinuria? So they looked at patients who had a creatinine of less than 150, compared patients with HIV and DM compared to patients with only HIV or only DM, and they noted that the incidence of proteinuria was more than double. So it was actually triple in those with HIV DM compared to HIV alone, and double compared to those who had DM alone. So definitely additive. So peripheral neuropathy, unfortunately there are not many studies, because most of the studies done in peripheral neuropathy in HIV has excluded diabetes because it's like a confounder. But there are few studies which have actually looked at this, and the large studies, around 3,000 patients, have demonstrated that the risk is 1.5 to 3 times of peripheral neuropathy in patients with the HIV and diabetes compared to HIV alone. Locally, Kuka, who we did residency together with, he studied this in Aga Khan. His numbers were much smaller, there were 136, but he found a numerically higher prevalence of peripheral neuropathy in the patients with diabetes and HIV compared to HIV alone, but it was not significant. So when we look at survival, so this was another retrospective study done in the US, where they looked at patients with HIV alone compared to those who had HIV and diabetes, and HIV, diabetes, and CKD. And if you look at the 15-year survival, it's approaching 50%. in those who had HIV, diabetes, and CKD compared to those who had HIV alone, which is around 90 something percent, and HIV and diabetes, which is around 80%. So definitely, this study of course was confounded because those who had the HIV and diabetes were much older than those who had HIV alone, but definitely this is an alarming trend. So when it comes to management considerations, there are some things which will apply across the board, whether you have HIV or not when you have diabetes. So lifestyle modification, dietary modifications, weight loss, exercise, pharmacotherapy is the same. There's no difference. Cardiovascular risk reduction is the same. There's no difference. And then you still have to screen for complications. But there are some caveats which you have to consider in patients who have HIV and diabetes. One of them is the use of HbA1c, and one of the things you have to be very vigilant about is drug interactions. So can you use HbA1c to diagnose diabetes and HIV? So it's been shown that actually HbA1c may underestimate glycemia in HIV infected. The mechanism is really not known, but it's thought maybe to be due to chronic hemolysis in HIV, and the discordance was associated with a high MCV, abacavir use, and a lower CD4 count. This was a study which looked at patients who had diabetes as defined by a fasting plasma glucose of more than 7, and then they looked at the HbA1c, and using a cutoff of 6.5%, actually the sensitivity was only 40%, so you missed like 60% of the patients. So a cutoff of 5.8 had a higher sensitivity, but then you suffered with specificity, but that was the best. So as a result, the ADA does not actually recommend HbA1c for diagnosis of diabetes in HIV patients, and they recommend plasma glucose criteria instead. Now when it comes to monitoring, it becomes a bit tricky. So you can still use HbA1c, but you need to be more stringent, because if you get a patient with HbA1c of 7.3% probably, it might be actually be around 8% or something. So you need to tighten up on that. So drug interactions is key. I think the most important one is right on the top, metformin. Because as I said, the first line is INSTI-based regime, which is dolutegravir, and dolutegravir significantly increases metformin concentrations. So if you are using metformin in a patient who's on dolutegravir, then you have to be careful, you have to monitor, and you have to limit the dolutegravir dose, the metformin dose to 1 gram total daily. The other drugs, thiazolidinediones, I don't think they are much in use, but they interact with protease inhibitors, which are mostly used for second line. So if you use them, then you have to monitor. The good thing, the new drugs, the GLP-1s and DPP-4, not much interactions apart from saxagliptin, which if you use ritonavir, then you need to adjust the doses of the saxagliptin. And then with the glyphosins, it's canagliflozin, again with ritonavir, which you have to adjust upwards. And then meglitinide, I don't think it's in much use. Now, what about statin therapy? So statin and diabetes go hand in hand, and it's no different in HIV. So all patients who have diabetes need to be on a statin, moderate or high, depending on the ACVD score. But also in HIV now, there was this recent trial called REPRIEVE, which looked at patients who are traditionally not going to receive statins, and they gave those patients statin, and they compared to patients who did not receive statins, and actually there was a significant reduction in major adverse cardiovascular outcomes, and as a result, statins are recommended in patients with HIV who have an ACVD score of 5 to 20%. The one which is recommended is pitavastatin, because of that study used pitavastatin, and the reason they use pitavastatin is because of drug interactions again. So I've just concentrated on the 3 main used statins here. Atorvastatin. So if you have a PI, then the PIs will significantly increase your atorvastatin levels, so that will become difficult. Some of the patients are on NNRTIs, especially efavirenz, atripla, TLE. So these ones actually reduce atorvastatin levels. So you have to now increase the dose. While if you're using a PI, you need to reduce the dose. Rosuvastatins, thankfully, there is no interactions with NNRTIs, but you still interact with the PIs, which thankfully not many patients are on. But if a patient is on a PI, then I would definitely recommend that you use pitavastatin. which there is no drug interaction. The dose is recommended is 4 milligrams. So let's look at our Kenyan guidelines and what they say. So they're recommending screening at baseline for all patients, and then for monitoring, they recommend either HbA1c or fasting blood sugar every 3 months, but you have to remember what I said about HbA1c. In terms of treatment, they've alluded to the metformin interacting with dolutegravir, and you need to reduce the dose, and of course, you need to continue having your complications checked with yearly ophthalmology screening and urinalysis and managing if there is proteinuria. So my take-home points is there is increasing chronic illness, including diabetes in patients due to HIV, due to improved survival. Diabetes in HIV is an additive risk factor for developing cardiovascular, renal, and neurologic disease, and it's associated with a lower survival. So principles of management are similar, except that you should probably not use HbA1c and use fasting blood sugar for screening for diabetes, and be wary of drug interactions. And the one I think you should always remember is, because metformin is universal in diabetic patients and dolutegravir is used in majority of HIV patients, is metformin and dolutegravir, and limit the dose to 1,000 milligrams per day.
Very much. Thank you, Dr. Adil. That was precise and to the point. You know, HIV is well funded, so their things are very well organized, well known, well presented. Next is TB and diabetes. We have, sorry, I forgot. We have Dr. Are you around? Is he around? He knows himself. Yeah, Dr. Farah Jamir is going to take us through TB and diabetes. Welcome, Dr.
Thank you very much. So I'll be taking you through diabetes and TB, and this is now the chicken or egg story. I'm not here to teach you diabetes. I'm not here to teach you TB, but this is just an interactive session that we need to see which was born first. Is it the egg or the chicken? But it's always a difficult question to answer, but we'll see how best we can make it as simple as possible and have pertinent take-home messages. So I have nothing to declare, just to thank the organizing committee for inviting me to make this presentation. So this will be my outline of the presentation, just a historical association for TB and diabetes. The burden of the deadly duo. This will be like an introduction, chicken or egg. I'll share with you a clinical case, risk factors, pathophysiology behind now this association to see which was born first, and then diagnostic algorithms and possibly work up that in summary what someone can use to at least diagnose either of the diseases, and then what are the treatment strategies that are being recommended or advised, and then now I'll make the summary. So I think we're all aware of this famous gentleman. For those who are doing diabetes, for those who are studying diabetes, for those who have trained in diabetes, they must have come across this gentleman. And he noticed that during his century of 19th, at autopsy, every case of diabetes had tubercles in the lung. So this is as serious as it is. These are other historical physicians. Avicenna is as early as 1000 AD, and he noted that tuberculosis by the Greek, which is called phthisis, and the study of TB, some of people call it physiology, which is still being used, especially in the North African region, was associated with diabetes. And then there's this Indian saint which describe now a cluster of symptoms, classically the symptoms of diabetes and more so TB. And they had a name for it by the name Mega Noikal. So I think someone with TB and diabetes, we can now start and call them this as a refresher from their ancient Indian. So the symptoms include now the obesity, which now we have another name as per advice from our colleague, glycosuria, thirst, incontinence, respiratory symptoms, and unconsciousness. Something to worry more about now, Howard Reed is also a physician in Boston. In the latter half that he stated that of 19th century, the diabetic patients appear doomed to die of pulmonary tuberculosis if he succeeded in avoiding deaths for diabetes. So I think this meeting was through diabetes. We are aware of cardiovascular deaths associated, but if you survive that one, there's another killer which is looking for you. And we are in that department. So as an introduction, TB burden is in developing countries continues to remain high despite efforts to improve preventive strategies. As our chair say, these are funded activities. There's a lot of focus in them, especially HIV and TB. But until recently, I think we're all aware we did not have BCG vaccines. Thank God, I think Kenya has participated in that IVI thing, and now we are getting it into our country. So we are that badly off. In 2022, TB was the world's second leading cause of death from single infectious agent. We are all aware, why second? The first was what? Maybe we trigger our minds? COVID, yeah. A single infectious agent, huh? But you see, TB is still there. So if there was no COVID, TB could have taken the lead. So in 2023, 10.6 million fell ill with TB worldwide and contributed to 1.3 deaths. This is a scary information. Eh? In the US, which as you're aware, they do a lot of these studies and they have a lot of registries. 1 in every 4 people with TB also had diabetes. So we need to take this seriously. In 2022, diabetes was the most commonly reported medical risk factor for TB. So diabetes influences TB incidence and mortality, and we are aware now the burden of diabetes is almost over 400 million plus globally estimated to have diabetes, and this burden is what? In the increase. So this is locally, we are not doing so well. That is our statistics. Incidence is 128,000 who fell ill, 88,000 were notified, but there were almost 17,000 deaths. And this is Kenya, as you are aware, is also among the 30 high burden countries for TB and TB HIV. And TB now remains a major public health problem in Kenya, and it was the 4th cause of death among infectious diseases. So I'll summarize this presentation, and then with this case, we'll go through the case and then finish the presentation, and probably we'll have enough answers to answer it then. We have this young gentleman, middle age, 35-year-old male, a smoker. We always, as chest doctors, we like asking them about pack years. 10 pack years, drinks alcohol. This is mnazi here locally, we call it, hawking at the Likoni ferry stage. So we're already now clicking, there are already risk factors here for what? For our conditions. He had a paralytic chest, right-sided chest pain, cough, fever for a week. So as normally they survive with these fevers until it's getting worse, so he sought medical attention. Nearby dispensary was given brufen, amoxicillin, and a cough syrup. So it got better, but not completely. But anytime these symptoms recurred, there was no need to go back to those dispensaries. So you keep on buying the medication, and then now with some symptomatic relief. But now things got worse. He started having difficulties in breathing, dizziness. Now at the ferry where he almost collapsed, someone took him and assisted and took him to a hospital. So they reported he was breathless, SpO2 was low, higher tachycardiac, tachypneic, BP was okay, but on the lower normal one, and had crepitations bilaterally and reduced breath sound on his right side. So chest X-ray showed bilateral opacities, mainly on the apices and right-sided effusion. Labs were done. He has an elevated white count. HB was 10. Normocytic, normochromic. CRP was above 200 from the report. Had a normal UEC. Pleural tap saw serosanguinous. 100-500 mils was tapped for a relief, and which showed an exudative predominantly neutrophilic. Sputum wasn't possible to get for analysis because he didn't have a cough then. It wasn't productive, sorry. So what is the diagnosis? What are our differentials here? So, of course, we are discussing TB. That will be our first diagnosis. But what they decided, probably this could be pneumonia with paralimonic effusion, with that serosanguinous, neutrophilic predominancy, with this could be empyema, with a differential, of course, diagnosis of PTB or TB pleuritis. Standard treatment in our local hospital, ceftriaxone and levofloxacin, and at least they decided to add hydrocortisone, being in probably pneumonia, and it has a significant role. So there was some minimum improvement, but this gentleman had worsening shortness of breath. So they had to call a physician who saw the patient had Kussmaul breathing. RBS was tested and it was high. Urinalysis showed 4+ glucose and 4+ ketones. So this is what? DKA. Diagnosed, so they thought hydrocortisone could make it worse, so it was stopped. So insulin was started and given IV fluids. He was better treated almost for 10 days, but he said, you guys, I need to say my njugus, and there's no way I'm surviving here. And the Good Samaritan, of course, it's someone who helps. So he decided to go home. Now, a month later, he came back. Fever persisted, low grade with a productive cough now. Chest physician was consulted. They did a thoracic ultrasound, and it showed effusion with septation and some opacities according to the reports. So this is a case. So these are our questions we need to answer. What was now the final diagnosis? Treated as empyema, not improved, and then got worse. Reasons for his high blood sugar. Was it there before the diagnosis of this infectious process? Was the infectious process brought this diabetes? We don't know. So we'll see after the end of the presentation. What other diagnosis tests will you recommend? Probably to confirm now this is TB, and this also, is it TB, or is there also diabetes? And then final diagnosis, treatment, and then we need to, of course, follow up our patient. So these are standard conventional risk factors that we're all aware. TB, so traditional risk factors, poverty, malnutrition, overcrowding, smoking, immunosuppression. And now with TB, HIV, and diabetes, we call it what? A deadly trio. So, and then now diabetes has been specifically been identified as an independent risk factor. And these are several studies that we've gone through. They're always saying almost 3 times or 4 more than any other risk factors. And these are our other risk factors for diabetic. I think I don't want to bring you back. I think these are things we've been discussed throughout. But family history, ethnicity, fat distribution, which now we always call it as obesity, but I think the term we've been changed. Lifestyle, dietary patterns, medications that people use sometimes, and then other medical conditions like gestation diabetic, other risk, cardiovascular risk factors, hyperuricemia. So these are risk factors. So anytime, why I'm bringing this to, anytime we get a patient, we need to ask for these risk factors and look for them. So that now we conclusively say, probably this patient might be having diabetic or also might be having TB. And this is the basics of our medicine. So the story begins. They look alike, but it's like which one was the first one to come out. So diabetic as a risk factor for TB. So we want to say it was the diabetic, the egg, which then the TB was the chicken, or the vice versa. So as I said, it increases the risk of TB. And active TB disease may present atypically now with this population of people. So you have to be very careful to kindly look for this TB in these patients. And it might progress very fast, and we'll look for reasons why it present with more chest and systemic symptoms. And more frequently, they always have a very high grade smear and culture positivity. So Another thing, what we commonly do in our local hospitals are chest x-rays. We are all aware that a standard TB chest x-ray will have what? Predominantly apical, because of its oxygen and everything that we always learned in school. But remember, in this population and also in immunosuppressed things, the picture is different. So there's always delaying of diagnosis, and because there's a delay of diagnosis, this patient has diabetic, the disease is more destructive. So you are losing the patient's lung if you don't pick this disease early. So they'll have cavities with, in PTB patients with diabetes, sometimes mimicking the pattern of radiographic TB seen in HIV patient. So the fever, hemoptysis, extensive parenchymal lesions, and lung cavities are more common with diabetic, particularly heavier and older patients. I think Rilwan, we can use them, we can tell them heavier than you're obese, a little bit well fed. So TB treatment outcomes affected. So diabetic increases the risk of treatment failure. Several studies have shown this, deaths and also relapse. And sometimes also we have reinfections. So what is the pathophysiology behind this? Most of the papers have said that diabetic impairs cell-mediated immunity. So there's and the poor glycemic control now. So itself, it affects. So for people who have a poor control, there is also affects the cytokine response and alter the defenses in the alveolar macrophages. And you know, normally the TB is affected by the bug, mycobacteria, tuberculosis. The entry is inhalation. The first contact of our defense systems is alveolar macrophages. So either these macrophages will clear the TB, so it will completely destroy it and remove it, or your immune system will engulf it and make it what? Latent. And then probably later it will reactivate in event now there is any additional risk factor. So most of the time patient will live without this reactivation. They said almost 10% will have an after some, usually the active infection might occur within the few months of infection when you inhale, but it can take years in a dormant, latent phase. So diabetic patients also show a huge reduction of bronchial reactivity, alveolo-capillary diffusion, elastic recoil, and also they have a reduced what? Ventilatory response to hypoxemia. So they tend to become sicker and sicker. There's this one for type 1s, but it's not really proven. There's this linked, there is a HLA associated, seems to be linked to higher frequency of pulmonary tuberculosis, and the other one was protective. But this was not completely proven. TB as a risk factors for diabetes, there are few dedicated studies to show the association. TB can lead to impaired glucose tolerance and new onset diabetes. Often difficult to conclusively label now, this is it, the TB as a risk factor for this newly discovered diabetic, or this patient had diabetes but no one screened and picked it. So pathophysiology, usually the most important thing that has been there in the literature is this stress response to infection, the insulin resistance or stress-related hyperglycemia. So sometimes you can try to be very aggressive to look for this diabetes, especially with our colleagues, and having been through this session, we've learned a lot of diabetes, and at the end of the day, most of these patients will definitely probably be not diabetic, just because of this additional stress. TB can also cause what? Pancreatitis. We are aware of miliary disseminated TB. It can affect the pancreas. We are told that TB can affect what? The whole body. The only thing probably they don't affect when you used to be in medical school is like the hair and the nails. So everywhere TB can affect, including now the pancreas. And we know it can affect the pancreatic endocrine function. And then medication. Some medication we use in TB, for example, TB pericarditis, they use steroids. So, and some people also use steroids, any with serositis. And this one can make patient now at a higher risk, especially for those who probably are pre-diabetic and no one had an opportunity to screen them. So this is just an illustration of how these two might relate. So there's this reduced cellular immunity and the reduced ciliary function, and then the TB itself, the stress response to infection, there's increase of these inflammatory markers, T-bag, pancreatitis, and the endocrine hypofunction. The reduced body mass index was not conclusively proven. So these are the diagnostic algorithm. For person with newly so a person coming to the TB clinic, or as a physician, you want to look for TB in this patient, person with newly diagnosed diabetes. You want to see, does this patient have TB, so that you can start actively treat it. So history, normal standard history taking, and is the patient already on TB? Yes, okay, so you continue medication. Not on TB, so you are looking for TB. So about obvious questions that we always ask: a chronic cough, at least 2 weeks and above, fevers, weight loss, or night sweats. Positive symptoms screen, then you take a sputum if the patient can produce sputum. If they can't produce, or you can refer to a TB specialist or TB clinic for follow-up. No symptoms, you definitely have to educate, because diabetes is a risk factor to get diabetes, so that they can always, once they get these symptoms, they can go to their primary physician as fast as possible. And then active TB diseases diagnosed, probably from the sputum, and then we'll take medication. No diagnosis, we'll definitely consider further evaluation if warranted, and is now at a specialized level. So TB patient at diagnosis or registration, so you want to rule out diabetes. So standard questions that you ask: do you have diabetes? Are you on diabetes medication? If it is yes, you continue medication. No, you screen. And the screening as the standard recommendation how you diagnose diabetes. So random sugars, fasting sugars, and HbA1c. But you are aware most of these conditions are chronic conditions. There might be an element of anemia, so you want to probably take that HbA1c later, or probably even if so it's obviously high, then you know the patient has diabetic and you treat. So what are the treatment strategies here for this duo? So diabetic patient with TB needs to be followed up at the TB clinic at least 2 weeks to the end of intensive. And this is obvious because most of the common cause, most of the common diabetic, as we are aware, is pulmonary tuberculosis. And for diabetes, as I alluded, first of all, they have mostly intense diseases. So most of them will be infectious. So sputum positivity, it always been high, even if probably they use clinical diagnosis of clinical features and X-ray findings, but bacteriological diagnosis is always high in diabetic patients. So there's a risk. So a risk, first of all, to spread the disease, because we are aware in a diabetic clinic, whoever comes there is already a risk factor to get TB. So you correctly advise this patient that having a TB, I won't be seeing you until probably in 2 months' time. But you'll be always in consultation about how well your diabetes is managed. PTB in diabetic patient treatment remains the same. So this is a standard treatment. And then TB patients with with newer onset diabetes. I'm just 2 minutes to finish the case, and then we take our home message. So standard treatment, but in acute setup, insulin is always recommended because of that insulin resistant thing. Most patients with new onset diabetic will resolve with TB treatment because of that stress. Once you've treated the TB, if the TB was as a cause of this diabetic and the pathogenesis we saw probably because of the stress, will resolve. And this will have to be monitored. But at the end of the day, the patient still remains high risk to get diabetes. So diabetes treatment in patients with TB similarly aims to control sugars, and the targets as recommended are less than 8 and 10 respectively. And for those who remain to have diabetes now, we have to refer them to the diabetic specialist for follow-up. And always remember the cardiovascular risk assessment in these patients, because both of them are high risk. So we need to check for smoking, obesity, excessive alcohol, hypertension, hyperlipidemia, and established cardiovascular, and we treat accordingly. So back to our case. Possible diagnosis, reasons for the high blood sugar, what other diagnosis testing will you recommend, final diagnosis and treatment plan, and then follow-up. So diagnosis. So diagnosis was obvious, TB, because we are discussing about TB here, and then TB pleuritis, and then there was a new onset diabetic, or is it a newly diagnosed diabetic? So from our investigations, this patient just has a stress-induced diabetes, high sugars, so it wasn't really diabetes. So high sugars, was it stress-induced, steroid-induced, pre-existing diabetic, disseminated TB pancreatitis, pancreatic endocrine hypofunction. So all these are questions you need to look for and answer them. Sputum, AFB's gene expert, bronchoscope with probably bronchoalveolar lavage or medical thoracoscopy with pleural biopsy. So these are advanced because we need to look for this TB until to the latter. Because if you miss it now, you'll have a destructive lung, and this patient will always be regretful that you've not gotten the chance to treat him early. And we know we can TB in a TIBA. So once you diagnose it, you treat it and you cure it. So diabetic, so is there a role of HbA1c in this patient has an HB of 10, fasting blood glucose, or GTT, or continuous glucose monitoring. So what was our final diagnosis? So after all these, what did you, so the diagnostic sputum they produced couldn't bear any positivity, so they did a bronchoscope. We did a bronchoscope, the BAL was positive, and this now we say probably new onset diabetes, and HIV was negative. Always have to rule out HIV in all TB patients. That is standard care. So put on medication and they need to follow up. So there's a global campaign, and this also have to include Kenya. So what is this global campaign? This is part of our take-home messages. As we are aware, TB and comorbidities, including diabetes, and then now it's embedded in Pillar 1 of to end TB strategy worldwide. So diabetes is there. So diabetologists, you have a role to play and you have work to do. Collaborative actions to address TB and diabetes. And what are these three main objectives in a whole this document that they produced is establish collaboration now between TB and diabetic programs to improve detection management now of TB in diabetes, and similarly the opposite, diabetes in TB patients. So finally, what is our take-home message? So there's this strong link between diabetes and tuberculosis. Not clear which comes first, chicken or egg, but is it important? You need to answer. It is yes or it is no, but we have to look for both of them. And this is now the bi-directional screening. Mandatory to look for diabetes among TB patients and TB among that, the diabetes patient. And if currently they don't have, anytime they visit your clinic, you have to ask the signs and symptoms, because these people walk around and TB is everywhere in our community. Linkage to appropriate specialized clinic for management and follow-up. And this one's now for either TB clinic. Diabetes, especially if initially in consultation and then later to prevent the spread, they can follow up after the intensive phase. And they need to establish local integrated and also collaboration now between our TB and diabetes program. Thank you for listening. So these are
Dr. Adil and Dr. Faraj, please take a seat. We'll have 2 questions. Two questions? Oh.
Thank you. My question goes to Dr. Adil. I'm interested in, are there any modeling or any data available for the space of HIV and renal-related questions, as well as, of course, for diabetes currently? Thank you.
There's another question. Let's take both.
Thank you very much. My question goes to both. Any of them can answer. The role of urine lamb. Their stories, I don't know if it's fact, a lot of false positive has been seen. And the fact that diabetes also, there's the impairment of the immune system. Can we use it as a tool to screen? And another thing, Dr. Faraj, I think they're going away from 2 weeks cough for the TB, and they're opting for cough any duration. What do you think about this? Are we missing that TB cases, given the fact that the statistics is still very high for TB? Thank you.
Let's take one more so that we answer all of them.
My question is to Adil. Adil, you mentioned that diabetes is almost 3 times. And then you have your first line as the tenofovir, which also causes renal decline. So for patients with HIV and diabetes, do you still put the first line or do you put them on TAF?
Yeah, please, let's take those. I think the rest will look for them during tea break.
Okay, good questions. Let me start with Steve. So I'm not aware of any modeling kind of studies, but we know that like there is an additive effect with kidney decline in HIV and diabetes. Yeah, I don't know if I've answered your question. The question on urine lump, so I think it is grossly overused, the test. You need to use it in the right situation. Right now, anyone who's got suspected TB will get a urine lump, and you see it looks for the lipoarabinomannan in mycobacteria. And we have to remember that mycobacteria are very ubiquitous. There's non-tuberculous mycobacteria, and often there's contamination during collection, and that can lead to a false positive urine lump. I would always prefer getting a diagnosis of TB microbiologically, because you'll get a gene expert, you'll get rifampicin resistance, and you'll also get a culture which will guide your therapy. So urine lump, use it in patients with HIV, especially who are sick, CD4 of less than 50 or less than 100. That's where it has been proven to have a diagnostic role. RIL1, yes, tenofovir does cause kidney dysfunction, but I don't think that upfront you should, like TDF causes renal dysfunction, and with patients with diabetes, I don't think upfront you should go for TAF, because you know TAF also leads to obesity and all those other complications. So you can start with TDF first line, and then if you feel like your patient is having renal dysfunction, then you can always switch to TAF. Faraj?
Okay. Yeah, thank you for the question. Maybe to answer our colleague here about urinary lump. The guidelines only states that urinary lump only have a role in HIV patients, and not that HIV patients, the severe form, the ones with CD4s almost less than 200. In any other circumstances, it has no role. I think if you are guided by that, it should be enough information. There is a lot of marketing now, it's available everywhere, people are using it right, center and back. And what I've, since my practice in Mombasa after coming back from training, have ruled out TB with a urinary lump positive by almost going to the latter, bronchoscopy, pleural biopsies and everything. And these patients, some of them might not even have any malignant. Some of them were even having malignants or just pneumonias which were not treated well. And sometimes we get a urinary positive, and we had a case with some colleagues here. I just tell them, okay, wait, repeat it after a week. It turns to be negative. So which one are you going to follow? So there is always this discrepancy. So if you stick to our guidelines and look for this TB bacteriologically, we are always taking this clinical diagnosis of TB very lightly. Anyone with cough, fevers, and night sweats, and remember, we all know these are B symptoms, can be in any type of chronic inflammatory or chronic infectious disease. Malignancy one also one of them. So I think we can always be guided by bacteriological diagnosis, as Dr. Adil has said, and probably in consultation now with the specialists in the field now to decide. And people sometimes have this notion of, okay, let's have a trial of medication, and this is now not recommended, because why are you having a trial and you have the experts to confirm this disease? So another question about cough, it's true. Patients who have cough sometimes might be, cough can be, many causes can cause cough. So always have that high index of suspicion if someone has this cough, and especially a recurrent cough, which is getting better and then coming back. If you rule out now other possible cough, causes of cough like asthma or COPD, or after checking the other risk factors. I think there was no other question. Eh?
Thank you very much. This is, I think, the first all-male panel we've had. Let's give them a hearty clap. Very good job. Thank you. And now I'll hand over to Dr. Nyawira, who will chair the next session.
Good afternoon. Now, my name's Dr. Nyawira, and I'll chair the abstract presentations. We had asked for abstracts and we got 4, and 3 of the presenters are here. I will introduce the presenters and the judges, and then they will come up. The first presenter will be Caroline Dongo. Caroline has a master's degree in advanced practice nursing from the Aga Khan University Hospital. She is a nurse practitioner at Gatundu Level 5, an NCD researcher, and a lecturer at the Presbyterian University of East Africa. She will be followed by Dr. Clemens Saga, who is currently doing his residency in internal medicine at the Moi International and Referral Hospital. We will then have Dr. Isabella Nzomo, a medical officer who is passionate about research, has a keen interest in NCD, understanding their treatment through research and clinical practice. Our reviewers or judges will be Dr. Bonnie Ale, who, guess me, sorry for that, Dr. Bonnie, wherever you are. Dr. Bonnie Ale, he's a medical statistician, epidemiologist, clinical data scientist, and internal medicine resident at KNH. To date, he has published in more than 28 papers in high-profile journals, including New England Journal of Medicine and The Lancet. He will be with Dr. Irene Jerry, a consultant physician endocrinologist and part-time lecturer at KU. We will have the 3 presentations, followed by a question and answer to the presenters, have the reviewers' comments, and this will be followed after that by Dr. Boni, who will give a talk on a study that has been sponsored by the Kenya Diabetic Study Group. These will be the preliminary findings of a sexual dysfunction study. We'll welcome Caroline.
Good afternoon, everyone. Good afternoon. It's clear now. Okay. It's not scrolling. It's not scrolling. Okay, good afternoon. Thank you to the KDS. Thank you to the KDS group for giving us an opportunity to present these findings of my study. I did it for my postgraduate master's degree in advanced practice nursing at Aga Khan University, Nairobi campus. And I developed this interest in diabetes upon one time I was working in the clinical area, and a theater list just popped out and we had about 5 amputations. So it was alarming to me as a unit manager, and I developed a passion for diabetes from then. I wouldn't say I was an expert in that, but I joined some of the study groups in the Kdsg, and I came up with this. So I decided to study on these factors which were associated with poor glycemic control among patients with type 2 diabetes mellitus at Gatundu level 5. It's in Kiambu County, Kenya, at the DCC. And I realized that diabetes remains a public health issue of concern globally. It has a rising morbidity and mortality. And globally, 422 people have diabetes, and majority are in the lower middle income countries. About 1.5 fatalities yearly, according to WHO. And the projections for 2030, 2045 indicate a concerning increase to about 10.2 and 10.9 respectively, and with urban areas reporting higher prevalence than the rural areas. So the prevalence of diabetes in Kenya is estimated to be at 3.3%, and we believe this is an underestimation because most of the patients who come to the facility come with incidental diagnosis, they present with other unrelated complications. That's according to the KDH's, Ministry of Health, Kenya Diabetic National Strategy of 2015. The one Kenyan study done in Kiambu County and Nairobi County comparing care of study between a referral hospital, a county referral hospital and national hospital revealed that about 80% had poor glycemic control, and non-adherence to medication was a major contributing factor, while other studies in the East African region identified similar higher prevalences, with medication non-adherence being the major key factor. Other studies also recommended drug availabilities in the facilities and health education on the patients to improve adherence. Several studies have been done across, and they truly indicate very high prevalence of poor glycemic control in Kenya, 81, Bangladeshi, 81, 65, 80 in Kenya, among others. And therefore, we realized that poor glycemic control remains still a great obstacle to diabetic management. And as we know, 1 in every 11 persons have diabetes, and the prevalence have quadrupled in the past decades. It's the 9th greatest cause of mortality, with type 2 DM accounting for 90% of the cases. And as we have known earlier, poorly controlled DM leads to complications as a result of poor tissue perfusion and peripheral neuropathy. And we've seen several studies revealing gaps in management, and we realized that little is known on factors associated with poor glycemic control in a rural Kenyan setting. So the study purposed to identify the proportion of poor glycemic control, as well as explore factors related to poor glycemic control. And therefore, we had 4 objectives: to determine the proportion of patients with poor glycemic control in Gatundu Level 5 Hospital. We also wanted to identify the socio-demographic factors associated with poor glycemic control, the patient-related factors associated with poor glycemic control, and the healthcare facility factors associated with poor glycemic control. The study was a cross-sectional study targeting a population of 400 with a sample size of 200, which was derived from Yerotamen method. And the sampling, the first participant was identified through simple random sampling, while the systematic sampling was utilized to recruit more participants, where every second patient who came for follow-up was recruited to the study. The inclusion criteria was any adult patient with type 2 DM, and other kinds of DM were excluded as other confounding factors. To HbA1c and to the capillary blood glucose were also excluded. Those are critically ill, kidney disease, CVS, anemias, steroids, and estrogen, and hospital admissions. Ethical approvals were sought in Aga Khan University, IRC Kiambu County, and Gatundu Level 5. The results, there's one slide which is missing. It showed that 36%, that's just a third of the participants in Gatundu Level 5 had poor glycemic control, and this was in agreement with many other studies. One study in Korea which showed that the prevalence of poor glycemic control in rural areas is lower than the urban areas. And this was quite remarkable results, because a similar study done in Kiambu County showed that 80% had poor glycemic control. So among the socio-demographic characteristics assessed, there were 7. There was age, gender, age, education, occupation, income, and marital status. Of this, only age was statistically significant, as identified by a p-value of 0.012. However, on logistic regression, the unadjusted ratios showed some risk in the female gender. There was risk in the more educated group. That's those who've gone to beyond education were 3 times more likely to have poor glycemic control. And those ones who are low-income earners were also likely to have poor glycemic control, while those who are also hospitalized were also at risk of poor glycemic control. The patient factors evaluated, only one head showed statistical significance of 0.007. That is the duration of diagnosis of diabetes. And we can see as disease duration progressed from 6 to 8 years, it showed a 7% risk of having poor glycemic control. Those patients on injectables were also, although not statistically significant, they were at risk of poor glycemic control 3 times compared to those on oral medication. Those who adhered to above 3 portions of vegetables and who walked 10 minutes in a day were also at lower risk of PGC. On the patient-related factors, drug compliance, as indicated by the variable of missed medication due to other reasons, and those who stopped medications, this group were almost 2 times more likely to have poor glycemic control, and these were significantly associated to poor glycemic control. The patient who used more cash to buy their medication, that's above 7,000, we are also 2 times more likely to have poor glycemic control. The last were the facility characteristics which were associated, and all these were not found to be statistically significant. However, there was a risk observed in those patients who walked long distance to the clinic, and those patients who didn't have a medical cover, and those patients whose cover did not cover for their medication. These groups were at risk of poor glycemic control. So therefore, we identified that there is reducing prevalence of poor glycemic control in Kiambu County. And we also realized that the older one gets, the better the control, as shown by the results that there was a 3% decrease in poor glycemic control with 1 year increase of age. The disease duration was also found to affect the glycemic control due to the declining cell functions. Those patients who are on injectables were also at risk, while those who adhered to medication had a reduced risk. Those patients who regularly checked their random blood sugar, apparently there was no difference between the 2 groups, those who checked their blood sugar and those who did not check their blood sugar. There was no much significance realized on that. This is according to in agreement with the ADA's recommendation, where they say that there's no need of a routine random blood sugar for type 2 DM unless the patients are on insulin, they have hypoglycemic episodes, they are on oral medications that increase hypoglycemia, or they are pregnant or planning to get pregnant. In adhering to medication and exercise, ADA recommends an increase in exercise and adherence into diet by taking 5 servings of vegetables and fruits and eating small portions of carbohydrates. On the healthcare facility factors, we realized that all those patients who received their medication in the facility, they had better controls, while those with a medical cover, they also had better controls, and this was consistent with the ADA's recommendation that the healthcare practitioner should consider insurance coverage guidelines and expenses of care related to non-adherence while creating the treatment regimens. The study had limitations in that only that 6% of the patients had HbA1c, since the study initially aimed to target the HbA1c, but only that 6%, which was not statistically analyzable, and therefore a random blood sugar, which every patient undergoes on a clinic day, was used as an alternative in line with the ADA's recommendation. The main uptake of the follow-up was low, and therefore there was information, the gender was not interviewed equally, while there was information bias, since the study took place during the election period and the participants could not understand why they should disclose their income and other things. So the conclusion of the study is that the poor glycemic control is reducing in sub-Saharan Africa. The younger age group is associated with the poor glycemic control, and therefore there's a need to focus on this. The female gender, the low-income earners, the higher level of education people, and their unemployment status showed a risk of poor glycemic control, while medication adherence and longer disease duration was associated with poor glycemic control. That is, a poor lifestyle showed a risk of poor glycemic control, that's the diet and the exercise, while those patients who lacked the medical insurance cover or those who traveled long to their clinic and those who missed obtaining their medication in the clinic were all at risk of poor glycemic control. Therefore, the study recommends to design a training for the healthcare workers and the patients with an emphasis on medication compliance and lifestyle modification in the clinical practice to identify gaps and availability and affordability of medication. There's a need to focus on policy and medication availability in these facilities. And a future research recommends a qualitative study to assess perceptions on provision of care, which were factors that were emerging during the study. I'd like to acknowledge my supervisors, Wesley To, Diana Kasaman, Dr. Wairagu, our consultant physician, endocrinologist in Gatundu Level 5, and the DCC staff.
Good afternoon. I would like to thank the Kdsg for this opportunity to present this. It was a thesis presentation for my postgraduate studies, and I will also acknowledge my supervisors, Dr. Jemima Kamano and Prof. Paul Oyu. My name is Clemence Msaga, and I will be presenting on precipitating factors, presentation and outcomes of diabetic ketoacidosis among patients seen at Moi Teaching and Referral Hospital. So, onto my background. Globally, we have 537 million adults living with diabetes, with 8.75 being having type 1 diabetes and 528.25 million having type 2 diabetes. And this was from the IDF 2022. So there is a projected increase in numbers of diabetes in sub-Saharan Africa, whereby we have a prevalence of 4.5% that is predicted by 2025 in Kenya. Currently, it's 3.3%. So diabetes and its complications is ranked by WHO as the 4th contributor to morbidity and mortality due to non-communicable diseases. And then it's the 9th leading cause of death globally. And DKA prevalence is increasing with an increasing prevalence of diabetes. And DKA is characterized by 3 things. You have hyperglycemia, you have your ketoacidosis, and ketonemia. So you have ketonemia that leads to metabolic acidosis. So on to my specific objectives, we wanted to describe the factors that were precipitating decay among patients seen in MTRH, to describe the clinical presentations of decay in patients seen at MTRH, and to determine the outcomes of decay among patients seen in MTRH. It was a prospective study done in a span of 1 year at MTRH, and we acquired 120 participants. We recruited them through consecutively sampling, and the inclusion criteria were known or newly diagnosed DM patients who made the decay criteria and were 13 years and above. We used the Stata software version 16, and continuous variables were summarized as mean and median. Categorical variables were summarized as frequencies and percentages. For associations between the independent and dependent variables, a bivariate analysis was done using logistic regression, and all the test results were considered statistically significant with a p-value of less than 0.05. Ethical clearance was gotten from Moi University and IREC, MTRH IREC. So there's one slide missing. Onto the social-demographic data on the results, we found that the mean age was at 35 years, and we had a female predominance of around 60%, and we found out that maybe we concluded that it's because females have better health-seeking behaviors, and also if you looked at from our clinic, we have more females than males, and most of the patients also had type 1 diabetes. Onto the precipitating factors, New onset diagnosis of diabetes or undiagnosed diabetes was the most common precipitating factors at 37.5%, followed by missed doses. And we found that most of the patients who had missed doses, it was because of financial constraints. Most of the patients were not having they were not getting drugs enough, or they couldn't be able to buy the drugs. So it was mostly due to financial constraints. And then it was followed by infection at 35.8%, the most common infection being pneumonia, followed by UTI, and then followed by TB. And then the other precipitating factors like stressful conditions, e.g. stroke, or patients who had steroid-induced diabetes were at 12.5%. On to the clinical presentation, most of the patients were presenting in a dehydrated state at 97.5%. And we concluded that maybe most of these patients usually don't come at the health-seeking behavior of these patients by the time, because of also the polydipsia and polyuria that they usually have. So they come in a very dehydrated state, followed by polyuria and polydipsia at 95 and 93.3%, and general body weakness at 85%, with nausea and vomiting with abdominal pain coming in handy next after those. So on to the outcomes, we found out that there were 3 outcomes. The day out of DKA, so that's the resolution of DKA, the length of hospital stay, and in-hospital outcome, like either if they are alive or dead. So we found out that most of the patients were coming out of DKA on day 3 at 49.1%. And the length of hospital stay was more at 6 to 10 days at that 55.9%, and we found that we had a mortality of 9.2%. So onto the factors associated with length of hospital stay and death, we found out that infection had an odds ratio of 2.49, meaning that most of the patients infection was, patients who had infection were 2.49 times more likely to have an increased length of hospital stay, and those who were admitted in the last year were 5.74 times more likely to have an increased length of hospital stay. And we associated it to the fact that these people who are admitted in the last year usually have a tendency of not having a controlled sugars, so they have hyperglycemia, so they tend to stay longer in the hospital. And then newly diagnosed diabetes were 5.19 times more likely to die than non-diabetes. And severe DKA also had an odds ratio of 1.41 times more likely to die if you had severe DKA rather than if you had moderate DKA. So from the results into the discussion, we found out that newly diagnosed DM, like the way I mentioned it, that we have newly diagnosed DM at 37.5%. And this study was similar to Abunga et al. In KNH. That was a study that was done in 2018, where she found out also that the percentage was 45%, but for her study she had a smaller sample size of 42. And then also Mekonnen et al. Had the similar findings, but it was different for Thejitaron et al. A study done in Thailand, whereby the most common precipitating factor was poor compliance at 35%. And this was because Thejitaron was looking at type 2 diabetes patients. Onto the clinical presentation, my findings were similar to Chaudhary et al. But I had more of altered mental status patients at 54.2%, because my study had more of severe DKA rather than Chaudhary et al. Who had moderate DKA and Mekonnen et al. Who had mild DKA. Onto the outcomes, my study had if you look at the numbers, resolution of DKA was at 3 days, length of hospital 6 days, and mortality 9.2%, which is very different from Thejitaron et al., who is in Thailand, at 8.5 hours resolution of DKA. And this was because in Thailand, it's a developed country, whereby we are having specialized endocrine center, and they are being seen by endocrinologists. So that's why we have a good number of patients coming out of DKA early, and mortality rate was 4.3%, was really low. But it is, if you look at our study in 2023 and Ethiopian study in 2015, our numbers are almost similar, which we are, and that was 8 years ago. And because by 2022, Ethiopia mortality rate had really improved to 4.4%. So it's something that we need to really look at and find out why is it so in Kenya. So onto my study strengths. This study used blood ketones for the diagnosis of DKA, which significantly improved the diagnosis of DKA. But the limitations is that mortality cannot be fully attributed to DKA because some of these patients had other comorbidities like infections. And then the definition of type 1 DM was based on age cutoff rather than autoimmune markers. However, this could not affect our main outcome. So the conclusion was that this study identified precipitants that are preventable, and the impact of DKA in MTRH is notable given the significant hospital stay and mortality. And the recommendations is that we recommend increased efforts towards community awareness of DM symptoms in order to improve early health-seeking behaviors. And then further research should be done on the audit or the management of DKA to identify the gaps leading to poor outcomes with the aim of improving the outcomes. Thank you.
Good afternoon, everyone. So I'm Dr. Nzomo Isabella Katanu. Recently cleared medical school in December. I'm awaiting internship. And on top of that, I'm a junior researcher. I consider myself lucky to be introduced to research in my undergraduate period and even get the opportunity to do 2 papers. I'm also interested in uncommunicable diseases because the scale has tipped, and we are having more mortality on NCDs than earlier when it used to be communicable diseases. I'll try to be fast. So I did a paper in my 5th year of study of undergraduates on compliance to pharmacotherapy and lifestyle modification among diabetic patients at Gatundu Level 5 Hospital. My supervisor was Dr. Collins Ongulu. He's a pathologist. He's not here with us. And Dr. Anne Wairagu, who is a consultant physician and endocrinologist from Gatundu, and she's also my mentor. This is my outline. So for the background, so diabetes mellitus, from now on I'll be saying DM, has greatly contributed to mortality rate due to the non-communicable diseases in the recent past. We all know it's associated with both acute and chronic complications when not controlled efficiently. We say it's the complications that kill you and not the diabetes. So for the statement of problem, I was going through a paper when I was in 5th year, and I saw that that was 2022. There was a national survey that was done, and it was reported that we have a prevalence of 3.3%. That is 4.6 people out of every 100 people. So in these 4.6 people out of 100 that were diagnosed with diabetes, only 44% of them knew about their diabetic state. I don't know if you can see we have a big problem here. And of the 44% that were aware of the diabetic state, only 7% had the desired glycemic control. Now that makes me wonder, if we are giving the medication and we are still not achieving glycemic control, we can do all the screening but still not prevent complications. So it made me want to look into non-compliance pharmacotherapy and the lifestyle modification. So for the justification, the results of this research were supposed to give information on the types of pharmacotherapy that were used by the study participants, the level of adherence to pharmacotherapy, the reasons for non-adherence, and the level of adherence to lifestyle modification. So because of this, we are going to create solution based on the findings, that is increase adherence, achieve desired glycemic control, and prevent morbidity and mortality. So my research questions were, what are the types of pharmacotherapy used by diabetic patients at Gatundu Level 5 Hospital? What is the level of adherence to pharmacotherapy among diabetic patients? What are the reasons for non-adherence to pharmacotherapy among diabetic patients? And lastly, what is the level of adherence to lifestyle modification among diabetic patients at Gatundu Level 5 Hospital? So my study site was Gatundu Level 5 Hospital. My population was patients attending diabetic clinic and also the inpatients. And my sample size was 165. Eligibility criteria was all patients who were diagnosed within the past 1 year and they were above 18 years. And to exclude them from the study, patients who didn't consent and those who were so sick and required urgent intervention. For the ethics considerations, I obtained approval from JQuat Ethics Committee in the Kiambu County Research Office. So for data collection, I used the self-report questionnaire, yes. So my results. So that is objective number 1. So from my research paper, I realized that 56% of the patients were on oral medication, 19% were on injectable only, and 25% were on both oral and injectable. And then most patients, that is 49.7%, were on biguanides and sulfonylureas. And then for the adherence to medication, which is objective number 2, I used the Morisky-Green-Levitsky adherence scale, where I was asking 4 questions, and then I graded the patients based on how they scored. So if you score 0, you have high adherence to medication. If you score 1 and 2, you have intermediate adherence. If you score 3 and 4, you have low adherence. And people who scored intermediate and low were considered non-adherent. So for the high adherence, we had 69.7% of patients being highly adherent to medication. And then we had 14% being non-adherent and 16% being intermediate adherent. Yeah. So the objective number 3, reasons for non-adherence. There were different reasons based on my literature review, which included cost of medication, lack of physician trust, taking medication for other conditions, pill burden, that is you're having different tablets, and perceived treatment efficacy. So from my paper, we get that 128 in terms of the range of money monthly, spend between 2,500 to 5,000 Kenyan shillings, and those who are taking medication for other conditions were around 66, and the pill burden, the ones who are taking different medication from different pills for the same condition, which is diabetes, were around 69. Lack of physician trust, we only had 8 participants out of the 165, and perceived treatment efficacy, those ones who believe medication wasn't helping, were 14. So for my discussion, I'll discuss what was statistically significant. So pharmacotherapy adherence was positively correlated to the pill burden and complexity and convenience of treatment delivery, whereby we realized that people who are on insulin were likely to be less adherent compared to people who are on oral hypoglycemics. Cost of medication in the previous studies was shown to be significant, but then in my study, it was not significant. So for the lifestyle modification, foot care scored poorly. Actually, I had 94% of patients say that they don't inspect their feet. And actually, most of them were shocked as to why I'm asking them about feet in a diabetic clinic. Followed by the use of right type of shoe. I'm scoring them based on poorly to the most adhered. So foot care, use of the right type of shoe, HbA1c monitoring, physical activity, diet, cessation of smoking, and alcohol intake. So patients who are non-adherent to pharmacotherapy were likely to be non-adherent to HbA1c monitoring, and this was statistically significant. Patients who were non-adherent to pharmacotherapy were more likely to be non-adherent to diet modification, and the association between adherence and medication and that of physical activity was not statistically significant. So my conclusion, most of my patients are on oral medication. The level of adherence was lower than the recommended level. We recommend 100%. The reasons for non-adherence to pharmacotherapy were pill burden, convenience and complexity of treatment delivery and type of medication. Most of the patients were non-adherent to lifestyle modification, and foot care scored very poorly in this study. So my recommendations: we need more aggressive follow-up on patients with injectables through community health volunteers, or we can even do simple phone calls to reduce level of non-adherence. And then non-adherent patients should be advised on ways to improve adherence, such as putting up reminders and counseling on the need for adherence. And then fixed dosage combinations should be considered in the population to reduce pill burden, and then promotion of health education on lifestyle with more emphasis on foot care. Thank you.
I want to thank the presenters. I'd want to ask if anybody has any question for the presenters. We can be able to take one question per presenter.
I think, thank you so much. I think all three of you did a fantastic job, very, very well presented, and very good studies. I'm actually quite impressed. For the study on DKA, just your name? Sir? Yes, so basically, I just wanted to know which was the predominant type of diabetes you had. And then it's a bit surprising to still get such a high number, percentage of 9.2%. And was there any specific protocol that was used? And just to give you context, we last year presented our study results done at the Aga Khan University Hospital. We are almost publishing that study. We found a mortality rate of like actually 0% that's attributable to DKA. We had, like you said, other comorbidities. I can see some of your patients probably even had COVID. You know, because it was that time of 2021, 2022. I don't know if you looked for COVID specifically contributing to the mortality, and like how many patients had resolved decay at the time of mortality. I think those are important questions I'd like to know.
Thank you. Just a comment. I think also who was taking care of the patients. So that data sounds very good, but it's also a highly specialized team taking care at Aga Khan, which sometimes, and all the equipment is available and pumps and everything. So you can also tell us who takes care of the patients. Yeah, the services are different probably.
Thank you for the questions. So yes, okay, it was after it was after COVID, so I didn't get any patient with COVID during that time, and most of the pneumonias, because most of the infections that this patient has were pneumonia, but the COVID PCR was negative. But so it was after COVID, not during the COVID period time. And then most of these patients are being, unfortunately, we are being managed in the wards, not in the ICU, and they're just managed with that's why I said there's a difference between our study and the one in Thailand and the one in Aga Khan, where you guys have specialized, yes, yeah, where it's,
limitation of our facility. You know,
okay.
it's facility-based limitations.
Yes.
I think that could come out a bit more clearly in the study.
All right.
And the type of diabetes, we found most
yeah, it was
of our
more of
patients
type
had
1.
Yeah, so we found more of type 2, but our population was 18 plus.
Okay, I found more of type 1 diabetes. But I said one of the limitations is that we didn't do any, we just did age cutoff. We didn't do any autoimmune studies to find out if it's really type 1. Yeah. Yes, now I can say they are not strict protocols. The protocols are there, but not, I wouldn't say everyone follows the protocols. Maybe Dr. Kamano can help me answer that one.
That's a very good question, yes. But I think the setting is very different. In a public hospital, and noting that majority of the mortality was from newly diagnosed. That tells you there was very late presentation because these are people who are coming from other hospitals, being referred from Kericho, Kisii, all over. Before they get transport and get to you, they're really critically ill. There's no ICU facility for them, so you're managing them in casualty and wards. It's under very difficult, very, very different from the Aga Khan situation. And I think it really speaks to the importance of, even as we set up protocols and care guidelines, really being very sensitive about the context within which they'll be used and who it is who will be taking care of patients. And also being very, and you can see the same similarities with the KNH study done about 3-4 years earlier at 11% mortality. It tells you the public sector, that is where we are operating at. And these are level 6, so they're probably much better than what you would find below. And there's still a lot that needs to be done.
Dr. Kamano, just probably comment on whether, the mortality could be appearing also high, but was it, I think it would be good to understand attributable mortality, like did the patients have DKA when they passed, compared to having resolution of DKA and then passing away? So that's now another probably underlying factor.
No, they had DKA because she was looking at time to resolution, and you can see the time to resolution was quite long, 6 days.
Good,
yeah.
Thanks.
Are there any other questions?
Thank you very much. The doctor from Moi University, in your study you got a sample size of 120 prospective study. You didn't say much about the sample size determination, and I just had this feeling that maybe 120 was on the lower side. Maybe you can comment on that.
Thank you for that. So I didn't put up all, I didn't want, okay, I wanted to squeeze the number of slides but I calculated the sample size and I got 120 because we did in a span of 1 year, and I was looking at DKA patients. So that was a sample for DKA, not just patients who come in with hyperglycemia. If I was doing hyperglycemia, it would have been a larger sample size than that. But for the patients who are having DKA, they were meeting the criteria whereby, because I was using ketones, and so if the ketones were more than 3, and they had hyperglycemia and RBS of more than 11.1 with metabolic acidosis, that was the criteria I was using in including the patients. But I'm sorry, I didn't put the slide up of how I calculated the sample size to 120.
Are there any further questions? There being no further questions, I will then hand over the mic to the reviewers to give us their opinion.
Thank you. It's always an honor to have the opportunity to be a judge for these abstracts. And it's good to note that this year, sorry? I was told to stand. So, because people won't even see me. So, I'm Boni Ale. I was judged with Dr. Irene, and I was saying that it's always an honor to be a judge for this abstract. It's good to see that this year we have different type of researchers, although they are like in the initial phase of the research activities, but the quality is still better compared to last year. I'm not saying the people of last year were not good, but you could see that these people were mentored and they have done a good job. So in general, it's a very good job, and they should keep continuing to improve themselves in research, getting a sound foundation in research methodology. It's critical because most of what I've noticed is about having an insight in the research methodology. So the first thing is that in general, the slides, the table, they are very crowded most of the times, and showing cartoons in the scientific presentation is not a good practice with fancy images. The research question most of the time was interesting, and so they are fairly good. They are useful for clinical practice, and they could change policy if we do that at a larger scale. So it's very interesting. It's also good to know that you can't solve too many research questions in one study. So you have to keep that in mind. You have to be specific about the research question you are looking for. So you can't have like many research questions for one study, unless you have a big funding and you are doing a very great study. So the method, the great comment for the sample size calculation. So it's not clear for us how do people come out with these such numbers, and we would like to just mention, you don't need to show us a slide for it, but at least mention on which data you base your sample size calculation on. The sampling method, sometimes you are doing two sampling methods in the same study, which make it very strange for me. The statistical analysis, most of the time we're brush out, and you do bivariate analysis, you don't go to multivariate, and sometimes you just show us just the unadjusted odd ratio when we are also expecting to see further the adjusted odd ratio later. So it's good to show us a very sound statistical method. And the outcome of interest, all the time when you are presenting, we don't know what are the outcome of interest. What are you looking for? How are you going to measure it, what you are looking for? For the results, most of the presenters didn't tell us what at the beginning is the characteristic of the patient they have in the sample. Because if we don't know what the characteristic, you cannot go further now and start talking about what you found. So you have to tell us what was the characteristic, what was, how are your patient. So, and I think just presentation skills, it's a stress and also many things. Don't hold on the pulpit, you can move around, you can look at the audience, don't look at your slide all the time, so that you engage the audience as well as you are talking. But all in all, I think you're doing a great job. This is the beginning of a great story. Don't give up, and try to bring up new evidence as we are treating our patients, because we need to generate new evidence in Africa for better practice of the clinical medicine. So that's it. Thank you for the opportunity.
Okay, Bonnie has shared most of the comments I had. So I think he summarized everything, but mine is to encourage especially the students. It's very impressive to see a student who's awaiting internship presenting her research. I mean, most of us did our first research when we were doing our master's, so that's quite impressive. The other thing also, I would like to encourage the males. I don't know what happens with males. Every time we seem to just have presentation coming from females. Kdsg has been mentioned that it's predominantly female, but even when you look around the hall, it's mostly females who are there. There's a high preponderance, skewness towards females. So I'll also encourage the male child. You're the one who is intentionally asking to be left behind by not doing research. Those are my comments. Thank you.
I would like to thank the presenters. You've all done a very great job. I would also like to thank our reviewers. The results from the reviewers will be presented at the gala dinner, so I hope I'll see you there. So I'll now ask Dr. Bonnie for the last presentation.
Thank you. Okay, since the room is empty, I will just do 5 minutes and okay. So this study is a study on sexual dysfunction in patients living with diabetes, and also we want to see what's the impact of having sexual dysfunction, what's the impact on the quality of life they have, the sexual quality of life. It's a study which is initiated by Kdsg and funded by Kdsg, and the study team is the one that you have there, and I hope most of them are in the room. So these are Kdsg members, and they are people from my team at Health Acumen. And I just want to point out that I'm not sure if it's showing, but well, it's just that people on ground, Dr. Victor Mukuni and Olushinale, and also the data manager, Eric Hume. So, the background, I think you know it already. Sexual dysfunction is not well reported in our settings, and you have high prevalence in these patients still. But we have very varying data on sexual dysfunction in Africa, and we need to generate in Kenya. We have limited data. We have found only just one paper that has been published in that regard, and it was a master's thesis. Despite the guideline that exists, which recommend to do a sexual activity assessment in this patient, we know that our culture and the taboos related to talking about sex, it's a problem. So most of the time, we don't do anything about it. We just keep quiet, and we see this same patient many times. And so our study then aimed to determine what is the prevalence of sexual dysfunction in this patient, and what is the impact that has on the quality of life, and how do we promote the routine assessment of sexual dysfunction in our patient, and this can improve the clinical practice. So the study design is, the study sites are 3, so it's multi-site. We have then Gatundu Hospital, we have the Aga Khan University Hospital, and we have the Lion Site Fast Eye Hospital. So it's an ongoing study which is currently happening in these 3 hospitals, and the study design is a hospital-based cross-sectional study which has started recently on 22nd April, and we intended to enroll above 800 patients. So the sample size were based on the prevalence that were reported in Ethiopia, and you have the prevalence for male and female, which is totally different. That's what leads to totally different sample size for both gender. And the primary outcome is the first thing you want to see. Do you have erectile dysfunction for men? And what's the score? Is it, or do you are not having erectile dysfunction? We're also talking about premature ejaculation, which I didn't mention there. So female, we want to see also, do you have sexual dysfunction or not? And based on the cutoff that we put there. So this is not the result of the study. So you have to do not take a picture of this result that I will show you, because it may change once we publish the paper. So this is just preliminary information. So this is the baseline information that you have to see. The mean age for this total population is 54, and the female and the male has quite different age means. So the male are older, but remember, you just have 43 female. So you can't compare these two groups. Don't try it, because we have totally different sample size here. Okay, so the body mass index, I know this is not good for nutritionists and people who don't like to hear that, but for the body mass index is 29 in this population. The education level, this is how it goes, and you have the marital status, and we have noticed that some people we need probably to think about if we want to include them in the analysis later, because if you're a widow, why are you asking me about sexual dysfunction? So, I mean, we have to agree on that. I won't decide on it. So probably, if you think it's not, it's still possible, that's fine. That's great to see that people react quickly. So alcohol users, people who use alcohol, they are quite a number, 50% of them, and you see that the majority are men. But once again, don't compare these percentages, and the smokers as well. It's good to see that probably none of the women are smokers. The clinical information are there. I won't go into the detail of it. So let's come to the information that you're probably looking for. So the female sexual function index, that's the questionnaire form that we use to be able to assess the sexual dysfunction in these women. And we can see that the overall mean score, it's 20.1. And this is probably not a mean, because it's a median, because you have a small sample size. You can calculate a means on it. But yeah, so it's preliminary information. So don't take it at the bank. The risk of sexual dysfunction was 63% among these women. So we calculate the score based on the cutoff that is there, 26.5. And we also then evaluate the quality of life, the sexual quality of life. It's not the ordinary quality of life, it's just the sexual quality of life. So the median score is 30 and we have like 37% of them has worse sexual quality of life. That's a good number, but it's just 43 people, so it's not really, we are not yet there. So for men, we want to see the premature ejaculation. So we assign this questionnaire the index of premature ejaculation, which has been used to see, do you have ejaculation control? Do you have sexual satisfaction? Are you frustrated about the control of your ejaculation? So, and we have realized that we have different views, and the weak ejaculation was present as 47%, and many of them has a low level of sexual satisfaction, which is around 49%. And like luckily, many of them are not too distressed, too frustrated, because it's just 14%. This is a big number because it's 100 something, so it's not that bad. And the erectile function, this is very critical for a man, right? So we try to see at each domain of the evaluation of the erectile function what happened. These numbers are not very good statistically because it's still not a big number. But it's good just to see that 90% of them don't have sexual dysfunction, but 10% of this population, this small sample size, has sexual dysfunction. The quality of life of men, hoping that we've been able to assess that very well, because I think we are men and we usually don't want to show our weaknesses. So we have the poor class is around 46. So 46 people have this bad. They don't have a good satisfaction. They don't have a good sexual quality of life. That's quite a big number for this small sample size. So in conclusion, this is still an ongoing hospital-based cross-sectional study. We have not finished, we have just started, and we still have a long way to go. And if you are in any hospital where these studies are happening, please send us the patients, and we'll be able to assign them the questionnaire and collect the data. We are collecting the data in real time. That's what allows us to be able to do this analysis. So we are targeting to have 420 women. We are still at 43. It's still very far from the target. And for men as well, the same thing. But in summary, for these steps, just know that 63% have sexual dysfunction and 37% have worse sexual quality of life. And for men, it's 46% who have poor sexual quality of life, which is greater, but remember, we just have 43 people in the women group. And 10% of them were found to have erectile dysfunction. Almost 50% of them have low level of satisfaction, of sexual satisfaction. Remember, us men, we may not be satisfied for sex most of the time, so it's a bit biased. So that's the preliminary result that we have for this study, which is still ongoing. And this study of Kdsg, Kenya Diabetes Study Group, we want to acknowledge the doctors in the hospital who have supported the study. They may not be PIs or co-investigator, but Dr. Shilpa has been very useful and very helpful for us in Lionside Hospital. We want to thank her. Most of the research assistants are telling me Dr. Njenga is sending us many patients, even though Aga Khan is not easy for us to get patients. So, and Prof, thank you for sending us the patient. So that's it for my presentation. Thank you for your attention. Yeah, there is Q&A. Because I'm not the only one who has conducted the study, I think there are many people here who should be answering the question. So my presentation is just on behalf of the AROS team. The microphone? Yeah. So where are the other PIs? Because Prof wants to ask questions, you don't let me answer the
Mine
question
is
alone.
actually, you can answer it, Bonnie. I've always wondered in studies of sexual dysfunction, where is the role of intimacy with sexual, because you don't see that there. It's a qualitative aspect, but I think sexual satisfaction has a lot to do with the intimacy of the relationship and how the relationship is. And that you may have skewed or biased results depending on the understanding of what is it. So sometimes they say, I have not had two, I didn't do it twice. That is then a bad sexual quality of life. So can you explain how you would get very hard data on this and what biases come out of that?
Yeah, so these are validated questionnaire, luckily. That's why we did not use questionnaire which are not validated, and validated in this specific population as well, and probably less validated in the African population maybe, but it's still questionnaire which are relevant for our contest. So I understand the fact that probably, yes, the fact that we are not going further to see the context of the relationship they have, if how that can impact the sexual dysfunction. But I think the questionnaire are very thorough, they are very long, and they assess different aspects of life of this patient. So they actually try to assess also those components, but not as we could do on a semi-structured interview. Because these are questions that you ask and the person answer. So maybe if another component of this study could have been, let's do a qualitative aspect where we do a semi-structured interview and we hear the feeling of these people, what do they think and what is going on in their marriage, if they are married, and all those kind of stuff. Yeah.
Yes.
Thank you.
Can I say something?
Yes, please.
Yeah, thank you very much. Can I see again your table, or now you are assessing the sexual satisfaction in females? The table. Go back to the table, yeah.
Yes, is it this one?
Yes, that one. I don't know how you are scoring, but I don't know when it came to the pain. Are you talking about the numbers, or these are figures which when you put accumulatively it will give you a figure which will read the satisfaction? Because if you were to do that, the absence of pain would actually be very high when there is no pain. So I don't know. I don't know how you arrive at those figures.
Yeah. So it makes sense. And just I'm warning you again, this is for 43 people from which we collected the information. And these questionnaires are not based on each, there are many questions around each domain. So around each domain, you have different questions. So we don't ask the question, are you satisfied? Yes or not. So it's not like that. Are you feeling pain? Yes or no. So it's about a domain that we explore with different questions. And at the end, there is a scoring process of how the numbers are put together. And they are not just all addition of the responses. So sometimes there is a weight that is put on each questions to be able to come out with a mean score. And right now, the interpretation is completely biased because you have 43 people. So thank you for your question, and I understand your concern. I like your insight as well.
I have two questions. One is very straightforward. When the table you've just shown, the 3.6 median is out of what? Is it a score? It's
Yes.
very hard for us to figure out what it means because there is no...
They are all
What's
scores.
the denominator? What's the total score one could get?
So the scores are calculated for each domain. They are not calculated for the overall domain. So for each domain, you calculate the score, and then we have the overall score. So it can go up to 77, and it depends on each. So right now, if you see 3.6, once again, if you do the mean score, which is supposed to be the means for the total number of 43 people, you cannot get the, I almost do not want to show this table because I know the confusion that you would have brought, because this is based on the question that we assigned to only 43 people. So the 3.6 that you have is not the means of the total when you add desire, arousal, lubrication, or satisfaction. But it's only when you stay at the satisfaction level and when you do the median score.
It's 3.6 out of what for desire? What's the total score one could get? What's the lowest they could get? What's the highest? And what does it mean?
Yeah. So for satisfaction, for instance, I can't remember for off-head, but the mean score, I think it's between 20. I think it's between 3 or 2 and 20. So it depends on, I can't remember the scoring of each one. That's why I've come back to do the mean score and then being able to classify based on the total sexual function. So it's a very lengthy questionnaire with a process of calculating each of them. I don't have the detail on each range for each of them.
Okay, just on on a slightly different trajectory. It's, as you said, this is a topic that brings in a lot of emotion and fear and stigma, and so very likely to give you desirability bias.
Yes.
And I would really love to know what steps the study group took to reduce that bias. Who are the research assistants? How old? Are they female? Are they male? If it's a female who was being interviewed, who was interviewing? If it's a male being interviewed, I would imagine interviewing an energetic man by a very young, beautiful girl. He would really like to give very nice data. So, who are the interviewers?
Which makes sense. So what we try to do is to try to balance. First of all, they were trained and on the questionnaire on how to use it. And the people who were collecting the data were interns or doctors. So those are the two group of people. They were not research assistants who were not in the medical field, and they were only interns and doctors. And the questions, we try to say, okay, if you are a man, you assign the questionnaire to another man, but if you are a lady, you assign it for a lady. But when the study was running, we realized that the male patient were not having any issue in discussing with the lady. So that's why we did not continue to distinguish between both, and we leave both of them to assign the questionnaire. Because at the beginning, we were very skeptical to leave a lady asking the man about his sexual function. But what we realized, because they are doctors, they felt that there were no issue, and these people were at ease. But really, it's probably the person who is assigning questionnaire dependent as well, the kind of results we will have in this contest. And that's the kind of bias that could happen in this study, and that's a limitation. It will be better if it is the treating doctor who is assigning the whole questionnaire. But we know we are very busy in our clinic, so we can't stop and asking all those questions to the patient. But that will be the best thing to do, because they have trust between the doctor, the treating doctor and the patient.
Maybe just to add to that, I think, just the patients knowing that it's a doctor, qualified doctor who's asking, and we as the researchers, or rather the clinicians in the room, also have been priming patients, And anyway, we ask, like, at least in the clinic that we have, we do ask as routine on sexual function as part of our overall complications, screening. But there are some patients who go directly before even they come to see us. So that's somewhere that if we do get challenges, then the patient would come first to us, and then we send the patient after we have discussed with them. So one way of trying to mitigate that.
Interesting. It's good to see that even if there were few people in the room, we are having a discussion. Is there any other question? So this is one of the first study of Kdsg, and watch this space. It's just the beginning. We are going to have different other studies, and from this study, we have quite a number of information that we are getting. And in the next conference, we will probably have numbers of papers which will be published out of this study, because we are going to use the wealth of information we have from this study. Thank you.
So I'd like to thank Dr. Boni and all the PIs for this particular study, and of course the Kenya Diabetic Study Group for making it possible.
So I'd just like to inform that the PIs are in no particular order. It's all PIs, all of us that are in the study.
I'll now hand over to Dr. Nicola.
Thank you, Nyawera. Thank you, everyone, and for actually staying until this long. So a few announcements before we go. There'll be a flyer put up for DMI Walk, which is supposed to take place on 6th of July. They'll be selling their t-shirts outside here at 1,000 shillings. So if you're interested, please pass by and buy a t-shirt. Gala dinner is at 7 in Arabuko 2, the next room. So please be ready. You remember the theme is Swahili night. If you're not in Swahili, please don't come.